This conference will now be recorded.
Hey, welcome for Rayz Mrcog Part 3 Introductory session. I am your mentor, Dr. Rashmi Patil, and today I'm going to tell you a few important things about what the exam is going to be, give you a brief introduction regarding the pattern of the exam, the domains that you are going to be judged upon, the modules that you need to be knowing, and also some brief things about the course as well. Now, from here on, there is no looking back because this is the last step that will make you get your MRCOG degree that you have been giving exams for. To sit for the Part 3 exam, yes, you must have completed and passed Part 2 and also have your assessment of training approved. This is very much essential. What does this mean is you should have 4 years of experience in working in the Department of Obstetrics and Gynecology, and that work experience has to be produced and submitted in your assessment of training when you log in into the RCOG official website. So you'll be getting that assessment of training done through the website itself. So you have to upload all your documents. If you have done 3 years of post graduation, 1 year of SRship, or 2 years of post graduation followed by another 2 years of work experience, so total number of experience that you have to produce is 4 years, which is including your post graduation. Now, official RCOG website has all the details that is available. This is the new website, and if you go into careers and training over here, you'll be getting all the details regarding the exams also. Briefly speaking about the Part 3 MRCOG upcoming dates. Remember, they have marked it as 8th and 9th of May 2024 and 13th, 14th of May 2024. And the upcoming November exam, which are later going to be 6, 7, 11, 12. Again, it's going to be reconfirmed in November. These are the tentative dates. The final dates, everything, the MRCOG, they'll release it. And the entire plan that they have is the venues are going to be Chennai, Malaysia, UAE, London, Delhi, Singapore. So whichever is the closest center, you will be you want to give in that center. But whichever is available, like in your country, please go ahead with that. That should be your first option, the closest nearest. It is nothing like some centers have a good pass percentage, some have not. You have to do well in your exam. Just to that's all that is essential to clear the exam. The Part 3 MRCOG fees, which is there, so there it depends on the banding. So there is band A, B, C, and UK and Republic of Ireland, they have different fees. So if you want to check into your band, so this is a column that you have to log in and see which country is allocated to which band, and accordingly, this will be the fees that you may have to pay during your booking. There are certain deadlines that RCOG has released in the website. So if you have any disparity, you have to ensure the home address and the email address, everything are up to date. So make sure Monday, 5th of February 2024, before that, you have checked your home address and mailing address and whether they are up to date. And any ID proof, the identity card, that whatever you're carrying, all the names, everything has to match together there, that the evidence that you're going to produce that you are the candidate who has come to give exam, and the name that is showing in the RCAG website, everything has to match. And home address, email address, because the preference is given there. So if you're giving an exam in India, you're in Indian origin, so they would give you the centers which are there in India as your first preference there. Now, assessment of training deadline is 25th of January 2024. So if any of you have not uploaded the forms, your certificates, everything, go to the assessment of training. You have to log in into your website with your account and get these assessment done, because after it may take a month also to make sure that your assessment everything is up to date. So do it right away. Whatever documents are there, just scan them and you have to upload it. And priority booking window open, so there are certain set of people that they give the first priority, like they are not able to book since long time, and this is the first time they are appearing. So there are certain criteria which the RCOG fix as a priority candidates. They get the mail to book the seat for them by 29th of February. So that is the date when booking window opens for the priority candidates. And for them, the booking window is going to close by 4th of March. But trust me, till 4th of March, seats won't be available. All the seats which are kept for the priority booking get filled up by 29th February itself. Within like most of time, it is like couple of minutes, the seats are booked. And some times it has extended to a couple of hours also. But make sure the time the RCOG website opens up the booking, that is the time you need to click and book it off then and there itself. So I'll be guiding you through the exam booking as well. Booking window, second time it is going to open up on 7th March. So these are the candidates who are giving first time or they have applied, and everybody, if there are certain seats that are left off in the priority, all those seats are going to be kept for the second window booking also. And second window booking is open for most of all the country people everywhere. You can book the seats, and the priority for Indian origin, they're going to give India as the first reference centers, then other countries similarly, or whichever is the closest one, they can go to that country and give the exam. So the priority is given in that way. The second window is going to open on 7th of March. So please take out your calendar and mark these dates for yourself. So one is your deadline, that is important. That is the 5th of February. And before 25th of January, make sure your assessment of training, everything is done. If you have already done, or if any of you have given an exam before and it was unsuccessful attempt or something, you don't have to upload these AOTs again. So once it is assessed means you are eligible to give the exam. So you don't have to do it again. But in case if you have not done and you are the first timer that you're going to appear for this and still the assessment is not done, then please make sure before 25th of January this is done. Remember, for the priority booking, it's going to be 29th Feb, and the second booking, it is going to be 7th of March. All these dates are important. Mark them in your calendar. The result, most commonly, it takes 1 month. So the tentative result, what they have told is 12th of June 2024. So let us speak.
No, ma'am. No, ma'am.
Yeah, tell me.
Ma'am, one thing which I want to ask is, can you just explain what priority booking? I just missed that sentence.
No, priority, there are certain criterias which RCOG fixes. For example, there's a candidate, two, three times they have attempted booking, but they were not able to book, but they have not given exam at all. So, or some candidates, like, it has been delayed, or the candidates, again, they prioritize the criteria for them. And RCOG sends the booking link for them individually. So in case if you have
Okay.
not got in the first one, then definitely in the second one, everybody gets an attempt. So
For
the
7th
second
March?
booking when it opens. So yes,
For
the
7th
second
March?
attempt when, yes, everyone will be getting a link. So RCOG makes sure that whoever has filled in the assessment of training and it has been approved, everybody are going to get the booking link. Okay, so that
So,
if it is not for the priority, then definitely you will get the link for the next booking. So
so
that RCOG
basically,
makes sure.
yeah, yeah. For
Yeah.
big booking, we have to wait for their email.
Yes. So they will
Okay.
mail
Another,
you, and
yeah.
by chance, if you have not received, we can always contact RCOG through their official mailing address. So if any
Okay.
doubts or any clarification is required, they always reply to that.
So that
So
would be
any
sent
doubts?
before, yeah, that would be sent before 7th, now, ma'am.
Yes, definitely. So you'll
Okay.
get
Another thing,
well in advance.
sorry.
You'll get well in advance.
Okay, another thing which I want to ask, ma'am, is there any difference to choose the dates or the month to give the exam in May, November, related to the pass rates?
Nothing. Trust me. People like you have to be determined to pass whichever day you're appearing, whichever month of the year you're appearing. So nothing like May or November has good pass rates or anything like that. There is no
The
bias.
center, nothing.
Yes.
Okay. And the
Nothing.
dates, like
Just
you mentioned, there are three, four dates like 8th,
huh.
9th. So
Hmm.
is there advantageous that you take the exam later or early, something like that, or that also doesn't matter?
See, everything has an advantage or disadvantage. If you're booking it on the first day, you're like the first time. I wanted to finish off the stress on first day. So I like purposely chose day one for my exam. And I just, went it out. That's it. And the disadvantage is, as day one, day two, day three passes and the day four, they may get to know like, okay, which stations were there or something, at least an idea about what has been happening in the other 3 days and what exam scenarios were there. So a small amount of discussion can happen. But Day four can be like, a surprise station also. You never know. So my only thing is whatever day, whatever station, whatever thing comes in your exam, you should be
Mhm.
confident enough to pass and come. Okay, it's
Okay.
not like May or November. And the preparation should be such that whichever day, whatever circuit you're in, you're clearing your exam. That should be the only motive. So other
Okay.
things are all, they are the contributory factors, anything, don't depend on them. Just
Okay.
whichever date you have got a booking, the booking, they have limited slots. So whichever day, whatever slot is visible, just book it
Right.
off. Try to choose a center which is closer to your hometown. So or that will be better.
Center is not that important, but the slot is more important. That is what you're saying.
Uh, See, first thing is travel. Whichever center is closed, definitely you don't have to travel much to reach the center. So that will be one thing. The second thing is whichever slot is available on whichever day, just blindly book it off. So you don't have to worry much. Most of the time, day one, day two, people try to click it off because it's visible immediately. You don't have to scroll down and go to the other dates also. So they just book it off. So don't worry about all that. Whichever day, whichever center you're giving your exam, your only motive is to pass the exam. That's it. You should be the best in your circuit. That is all is important. Okay. So we'll make sure you people all practice so that which it shouldn't matter where and when you're giving an exam. You are just clearing your
Yes,
exam and coming out. Okay.
yes, yes.
So passing this part 3 exam, it leads to the membership of Royal College MRCOG degree, and that is also essential waypoint for the UK trainees to pass from the core training to the higher training. Like they get to choose for their ST6 and ST7 and specialities as such. And part 3 exam, like I think a lot of people have already done the homework, so they know that there are 14 circuits, 14 tasks in a circuit that goes, and each task is going to be based on one of these 14 modules. Sometimes module can overlap. Sometimes like labor, delivery module, there are similar scenarios and it can overlap. Teaching, clinical governance can overlap a little bit. Basically, these are the 14 modules which RCOG displays: the teaching, clinical governance, core surgical, post-op care, antenatal, maternal medicine, management of labor, delivery, postpartum, gynecology, subfertility, sexual reproductive health, early pregnancy care, gynecological oncology, urogyne, and the pelvic floor problems. Now, how does the exam scenario goes? You have 14 stations in one circuit. There can be simultaneously two circuits also running during the exam hours. In one circuit, 14 station means 14 candidates who are there. You get 2 minutes of reading the instructions that are put up outside the cubicle and 10 minutes to go inside the cubicle and perform your task. So they have these kind of small cubicles which are there in arranged in a hall, and they are in a circular manner. So you have to go in a clockwise, or the numbers that are being displayed, you have to just follow your path. For example, if you're candidate number 3, you go and stand in front of the cubicle of 3. You read the instructions which have been pasted outside that cubicle. You get only 2 minutes. There can be two papers, there can be five papers. So you have to make sure that your reading skill is very much like quick, and you're picking up the cues very easily there. It is essential, and that will come when you are doing your practice book. So I'll be telling you how to go ahead with that. So whatever station from day one that you're going to do, you have to make sure that you're setting a timer, and it is only for 2 minutes that you're reading your entire task. So you have to improve the speed of reading and understanding what is important in that station. There are some details like you have to remember their name. So you can just write it down in your notepad. Okay, this is the name that I'm going to address the person in this cubicle, and this is the age. And some highlights would be there, like a BMI would have been given, some blood group is given, Jehovah's Witness, if it is mentioned, then that you have to make a note. And some basic details like, for example, is she in an antenatal ward? Is she in a post-operative ward? So they would have mentioned where the patient is. And just you don't have to write down the entire story in your notebook that is given in the RCOG exam. So they're going to take back those notepads and the pencils also. So try to practice in your the workstation there, that whatever you're taking, you write it down, jot it down, only the keywords. It shouldn't be sentences. They are only the bullet points that you're going to write down. So in that 2 minutes, you absorb this particular scenario, the name of the patient, what is the age, where exactly she is, and what are you, or if it is something like you're entering inside and dealing with somebody, so what is it exactly? You just have to mention it in one corner. The second thing is you have only 10 minutes to perform the task. So make sure from day one, whatever case that you're going to perform, or whatever task submission that are going to happen in the Telegram groups and all, even in the live sessions. So I keep a timer of 10 minutes only. So we have to try to finish everything by 9 to 9.5 minutes. So keep that grace of 1 to half a minute, something extra, so that if any queries, anything is there from the role player side also, you'll be able to address that. So try to aim for 9 minutes. That should be the best time that you're going to do. So whatever task it is, I would say practice speaking fluently. That will come as and when you're submitting your task, the fluency will definitely come. Second thing, have a good tone of voice. So I'll be telling you how to go ahead and how we can modify that as well. So it is not, if you're talking in a good tone and with a good speed, even when you're dealing with a difficult patient, be it an angry, be it a grieving patient, sad, depressed, crying patient. So all these things, your sympathy, your empathy that you're showing, the tone of the voice, everything is going to be perfect. And with the same tone, if you're talking to your examiner in your structured discussion also, it should be okay. So try to maintain and have these soft skills developed. Okay, that is very much important. So in that 9 minutes, you should be doing a quick kind of a conversation. I would say do not compromise much on the speed, but maintain a good tone. That is going to make a lot of difference. You don't have to, if your role player is not able to understand you, they may ask you like, can you repeat something? That is a cue that you understand, okay, this role player, I need to slow down a little bit because she's not able to grasp what I'm speaking. But otherwise, most of the role players are able to understand. Like for example, now how I'm speaking in this particular speed, most of them, they are able to grasp that. So it is necessary that you should have a good tone. You should have a good speed the way you speak, because you have to finish your task in 9 minutes. Once the bell rings, you literally have to shift from one cubicle to the other side, start reading your instructions again, because this is how it goes. 2 minutes, 10 minutes, 2 minutes, 10 minutes. So it is a continuous circuit, and you have to finish all. If you're starting from the task number 3, you finish 3, 4, you start with your 3, 4, 5, 6, you go like that to task 14, you come back to 1, then 2. Once you have come back to the task number 2 in your circuit, that is when your entire circuit is getting over. And then the bell rings, you have to submit all your notepads, pencils, everything, and you just walk out of your circuit hall. So once the circuit starts, and you're not going to get any clock or anything like that to have a look, because that just distracts you. So that is the thing why I want all of you to practice with a timer. You know how fast you have to speak, you know how to modify things, you know how to take a break in between, like, pause for 1 or 2 seconds, let the role player react for what you have said. Just wait for that. You can count like 1, 2, 3, and then speak up. So these things and all I'll be teaching, like how you have to do it in your exam. Now, speaking about the task scenarios, whenever there is one person sitting over there, it's a role player task. So it is called as the simulated patient task. Your examiner is sitting, a role player is sitting, who will enact as your patient. You are not supposed to touch your role player. There is no physical examination that you're going to do on your role player. It is just sitting across a table. There is a chair and she's sitting over there. You come and sit across the table. You talk to her. You explain things to her. So you are not supposed to touch your role player at all. There is no examination that needs to be done in RCOG. There are stations where there are mannequins and there is a teaching station. Then definitely, as you're touching the mannequin, you're asking your junior to hold the instrument in this fashion and do the maneuvers. That is all okay. But when it comes to a role player who is your patient, you are not supposed to do any examination for your role player. And if there are any examination findings, they are definitely given given to you in the sheet that is there. Otherwise, when you want to ask for some examination findings, if the examiner has, they just tell you regarding the same. So you just have to go through the information that is written outside, and if any information the examiner has to provide to you during your structure discussion or something, they will hand over that information to you. The other station is a simulated patient task with the lay examiner. Now, what does this mean? So, a clinical examiner is a one who has all the background knowledge about the obstetrics and gynecology. So they are all the at a higher post. They are professors, they are lecturers who are sitting over there. They have cleared their MRCOG and now they are examiners sitting over there and judging you. So they have their own sheets in which the domains are being given and the points that have to be covered in each domain that is mentioned for them. They just sit and observe. They will not interfere with the conversation between you and the role player. They have to be, um, just a minute. Yes. So the clinical examiner will not interrupt the discussion between the role player and the candidate. They are just sitting and they are observing how your conversation is going on. They sit and they give your marks for that. A lay examiner is a person who is not having a medical background, but they are good in assessing your communication skills. They can see how effectively you are talking to your role player, how you're convincing things, how you're handling the emotions of your role player, be it an anger or they are, grieving, they're crying. So how you deal with that. So such kind of stations where communication is very much important. These lay examiners are planted, and your role player is the one who is going to talk to you and give out the information. So they have their own set of instructions that they are supposed to tell you. So they, if you ask a question, so they have their written notes in which everything is mentioned for them, that how they are supposed to talk to you or what is the emotion that they have to show to you during that particular task. And in case if you are not touching on those past points or something, they are instructed to ask you certain questions so that you, it guides you and make you ask them or answer so that you are getting those pass points, like asterisk points, what we say. So these role players, they have their own candidate instructions. Sorry, they have their role player instructions where everything is written for them, and they are there to help you people. They will guide you through that task, and only if you allow the role player to speak. There are candidates like previously they would talk for around 8 minutes and the role player hardly got 2 minutes to talk or tell what they wanted. The best thing is you ask the question, let the role player come out with all the information that they have. So it is very much essential. We ask them open-ended question. So we don't go inside the cubicle and ask like, do you have pain in your tummy? Do you have vomiting or something? We ask them like, can you tell me more about your concern? So it is an open question. So she'll tell, I also have vomiting, I also have pain, I had some bleeding episodes. So she will tell you everything that she is supposed to give the information to you in that particular task. So if you ask her, do you have pain? She may say, no, I don't have. So if you're asking some direct questions and you're expecting like an yes and no answer, no. We'll ask an open-ended question. Tell me about your concerns. Tell me about your, like, the purpose of today's visit. So she will tell about whatever things have been instructed to her. So this kind of an open-ended question is very much important, and the conversations, everything will be teaching you. Now, when there are two people who are there, clinical examiner, lay examiner, definitely this task is going to be maximum scoring station, because there are other people who are sitting and judging instead of only clinical examiner, right? So this particular task, if you enter the cubicle and see there is only one person sitting, it means it is a structured discussion where your clinical examiner is sitting. It's a kind of viva exam that happens. They'll ask you about a scenario, they will ask you a few questions and you have to answer. They will not uh, interrupt you or something. You have to give out all the answer or whatever thoughts are there, and then they will ask the next question. So it is a kind of one-to-one discussion that is happening in structured discussion. So if you see that only one person is sitting in a cubicle, then it's a structured discussion there. If there are two people sitting in a cubicle, it means one is a clinical examiner, one is a role player. The one who is sitting across the table, the first person who is very close to you sitting there is your role player. The one who is behind that person is your clinical examiner. So do not interact with your clinical examiner. You should have kind of tubular vision. Just concentrate on your role player. Don't worry about what clinical examiner is looking at you, giving expressions, nothing. They are just sitting quietly. They don't even show any emotions, nothing. They don't express anything. Whenever you say good things, bad things, they don't even nod their head. They are just instructed to sit quietly and mark you. So do not look at the examiner itself. Just have a tubular vision, look at your role player and just talk to them. And if you see that there are three people sitting, then one is a clinical examiner, one is a lay examiner, and the third one who is sitting across the table is your role player. By chance, if you have any doubt, just your role player's name is written there. So you can say like, "Hi, is this Kelly?" So she will tell yes. So the one who is going to talk to you and respond to you is your role player, right? And the cubicles, they are arranged in such a way that you move in that particular order. Previously there was oscillar system where the screen would change, but here you have to shift from one place to other. So you, when the bell rings and you have your 2 minutes reading time for the next task, you have to get up from your chair and go there and start reading, because that is when the timer has already started. So do not continue your conversation in the previous cubicle. You're losing your time for the next cubicle, right? So you have to say thank you or something and just get up from your chair. Whatever phase your interaction is, whether you still had to explain something, just leave it off. Physically, mentally, get up from the chair, just go to the next cubicle and read the instruction. So
एक सेकंड
you
है
have
वो
to, yeah,
जा रहा हूँ
Ruma, can you mute? Okay. So you have to make sure that physically and mentally you're getting up from the chair and go to the next cubicle. Whatever good things are done, the bad things happened, just leave it off. Your emotion should be very much clear. Do not get stressed with the previous performance. It went well, good. It did not go well, just leave it off. Just go to the next cubicle, read the instruction with a fresh mind, because you have to get yourself prepared for the next station. So you have to learn to do that from one station to others, and that will happen when close to your exam, the last month when we are doing all the quick revisions, everything. So you get used to that kind of doing tasks continuously. And there are circuits also that we start doing in the later part. So there you can take the mock circuits where you're given continuous tasks. So it is a kind of mental drain that happens, but yes, you will get used to that. And all the 14 tasks, there is no break. So you have to make sure that your stamina is good and you're doing everything continuously. So don't get physically and mentally drained during your exam. Now, each of this part 3 modules, whichever are there, there are certain categories on which you will be marked. These are called as patient safety, communication with the patient and their relatives, communication with the colleagues, information gathering, and applied clinical knowledge. Now, what each of them would mean? Patient safety, these are certain points which would indicate that you are a very safe doctor in handling your patient. For example, they may have some allergies, so you're asking on allergies, you're making a note of that so that you avoid those medications during the treatment of that particular role player. So these kind, and particularly confirming their details on the scan findings or anything, or the investigations that are being provided. So you know that this is not the wrong report that you're reading and conveying it to your patient. Okay, so you have to cross check with the patient details before you convey that information to them. It may be like somebody else's report and you're just telling that report to someone else. And communication with patient and their relatives, what do that mean? So it mainly depends on the soft skills, how we are going to handle things. As I said, the voice tone, the speed at which we are talking, taking 1 or 2 seconds pause. You know that try to behave as though you are in a real life scenario. That is what I tell all my candidates. Just imagine that you're sitting in an OPD dealing with your OPD patients, or you're taking ward rounds and there is a patient like this. There are some, interop challenges that you're facing, and then you're discussing things with your colleagues. So try to do these things in your real life scenarios and try to imagine that whoever is sitting in front of you, it's your real patient and how you deal with them. So if the patient is crying, we don't just do things in hush in the OPD and just finish it off, right? We show that empathy. We know how to console that particular patient in our real life scenarios in our OPD when we give some difficult news to them. Similarly, in your exam, when your patient is upset or this, just don't hurry with your information gathering. You say like, okay, I'm so worried, doctor. I'm really scared that this is going to turn out as cancer or something. She's very much worried, and you're going to give that report to her. Let her take some 2 or 3 seconds extra. That is still okay, but give her time. Say that, yes, I understand that, but let me ask you a few questions. Again, don't jump like this. So you have to build that, the bond with your role player who is sitting there. Just bring them into your confidence. It may take a couple of seconds extra, but that is still okay, because such stations are based on your communication with patient and relatives. They are not going to see your applied clinical knowledge over there in a big way. The way you're counseling them, the way you're handling them, the targeted information that you take in that situation. You are dealing with a patient who is having post-op complication. They are having bowel injury and they are very much angry with you, and we are not bothered about her cervical smears, what happened. We are not bothered about her mental health past 4 weeks. I'm worried about the situation. She's angry. I need to explain things to her. I need to tell her how the follow-up is going to be. That is important. So I'm not worried about her family history of diabetes or hypertension. So there are certain irrelevant histories that we are going to. I'm not asking her about blood transfusion and reservation. She's already post-op. She's in the recovery phase. She wants an explanation about what things happened. So I'm not going to transfuse blood for her. Then why ask that history? So you have to make sure that what is relevant and what is sensible in that particular task. Just because the information gathering, these points are there, I am not going to cover everything. But in the background of my mind, I know that these are the points, and which one is going to be applicable in this task. Only those things I'm going to ask. So I'm not going to keep on asking everything that is there in the general information gathering. No, you have to apply your sense and just see that, okay, is this going to help me in managing this case? Yes, I will ask it. No, then leave it off. What is important in this is handling that patient, the way you communicate with that patient. So just imagine that scenario in your real life, and then you need to communication with your colleagues and all. So it's a kind of multidisciplinary team that happens in NHS. So a lot of specialities inputs are taken to manage a case effectively. Communication colleagues could be in terms of your consultant that you're dealing with, your junior who wants to learn something, your midwife could be there, and how you're going to involve those people, how you're going to communicate. And it could be something like your colleague has done something and you have come to explain the complication which has happened in the previous surgery. A lot of things can be there. So this, how you deal such scenarios where your colleague is being involved, that is important. Information gathering, so I'll be running through the general information gathering template, but not everything is applicable in every station. We have to filter out our questions when we are dealing with the task. Speaking about applied clinical knowledge, yes, you all have passed part 2. It means that you have good amount of knowledge which can be applied in your part 3. It doesn't mean that you need to tell everything that is there in the guideline. Just a gist of the guideline management, that should be enough. You don't have to tell all these 1, 2, 3, 4, 5, 6 drugs or all the procedures, named procedures, everything. They are not expecting that when you're dealing with a patient. They would expect some amount of good applied clinical knowledge in your structured discussion. But when it comes to your simulated patient task, be it with or without your lay examiners, even if you explain the skeleton of management, that should be okay. So do not overburden yourself with too much of guidelines or something, but a quick revision, just key important points and management points is what I would say. You just have to brush up those guidelines because you are new to them. Like, you have finished your exams, everything, and it's still fresh in your minds. And if you speak about all the domains here, patient safety is very much important, and the way you communicate with your patient is very much important. Now, when it comes to simulated patient task with or without the lay examiner, sometimes all the domains could be tested over there. And when it comes to structured discussion, yes, there is no communication with your role player or communication with patient or relatives there. These remaining domains can be tested. Now, how do you get scored in your exam? Your examiner, they have the particular points in their mark sheet, and there could be 6 or 7 points in each domain. In that, at least 1, 2, or 3 points may be marked as an asterisk points, means they are very much important. So if you are missing out on those points, it scores you down. For example, in the patient safety domain, if there are 2 points which are marked as asterisks and the remaining 4 points are also there, you have covered the remaining four, but you failed to touch on those 2 points. It would mark you as zero because if you're missing both those asterisk points. If you touched one asterisk point and if you did not touch the other, you will be getting a score of 1, that is borderline. If you have spoken about both the asterisk points, you'll be getting 2. That is your pass in that particular domain. Remember that it is only domain.
Mhm.
It is, yeah.
Sorry to interrupt, ma'am. Ma'am, what are these asterisk points? I mean, I didn't get. Can you please repeat this asterisk one?
Asterisks in the sense that they are like key important points. For example, ectopic pregnancy medical management you're giving, and you're not explaining the follow-up. So that is not acceptable, right? So you have to tell them exactly like what should be the follow-up. So you're speaking about drugs, you're speaking about the complication, you're telling about the side effects, everything about the drug and how it is given, what is the dosage, what is the route, and you don't tell them when to follow. So that is not
Okay,
justified.
so
So
they will already mark everything in asterisks, and we have to tell those points particularly without missing them. Even if we are telling the rest of the story, but still we have to emphasize on those points. Is that so, ma'am?
emphasize, they will guide you through that. Okay, they may
Okay.
tell you few points. For example, she'll ask you, then if you are telling everything, she'll ask doctor, like, I don't want to know about the dose, everything, but can you tell me like when should I come back? So she will
Uh-huh.
ask you that question, the role player. Then she's directing you towards that pass point. It means she wants you to tell her the follow up. If there is a
Right, right.
complete
Yes, ma'am.
molar pregnancy is there, you have done the suction evacuation, your structured discussion is going on, your examiner is sitting. So he will ask you, if you're not touching on the follow-up there, he will ask you, like, so how do you follow up this patient? So they will ask you towards those asterisk points also in your applied clinical knowledge. The safety points and all gets confirmed. And if you feel that there is a O negative patient, something, he will ask you regarding, is there any special injection? So if you are missing out on certain points, is there anything else that you want to tell? So it means he wants you to look into that scenario again which is there in front of you. So one sheet will be put up outside the cubicle. The same copy is kept on the table inside. You can go through that if you want. So you don't get marked down because you want to, take couple of seconds extra to read those things or something like that. But try to finish up within 10-15 seconds and start off with your station. At any given point of time, if you want to just have a look or investigation something, so while talking to the patient, just say that I can see that these are your investigations. So 1, 2, 3, 4, 5, 6. You can read out and explain the same. So they will guide you. Okay, this is the negative blood group. So is there anything else that you want to tell? So they will try to make you go through your scenario again. So you will remember, okay, you need to tell about the anti-D. So for
Okay.
example, there is some allergies. Some stations are there where the role players will tell you only if they are asked about the allergy. So if you do not ask allergy, she may be having some severe allergy for which she carries some adrenaline shots also along with her wherever she is. So
Okay.
that is, if you are asking her allergy, she will tell. If you're not asking, she'll keep on telling about her high pressures or diabetes, whatever she is dealing with. But if you ask her allergy, she will tell, yes, doctor, I have this allergy and it's very severe. I carry adrenaline shots with me wherever I'm. So she will tell you these points. And that is an asterisk points in your patient safety. So you have to uh, speak on, like, that you will get to know when you're doing your information gathering. So those things I'll be teaching, like how to go ahead with that. So if you're covering both the points which are there in that domain, okay, so if all the 4 domains are there or 5 domains are there, each domain will have a set of points, and each domain will have at least 2 or 3 asterisk points there, which is expected out of you in that station. So even if one domain you're getting 0, the other domains you're getting a pass, it still means you would pass that station, even though you didn't clear one domain in one station. And overall, when they are judging you, they will give you a global marking. So they will look into all the stations, all the domains, how you have performed, and the final result is given whether you have reached the expected standard in that particular domain or not. Okay, they will not tell you station wise you have passed or not. They will tell you whether you reached expected standard in your patient safety domain in the entire circuit. You reached your expected standard in your communication or no. So it is a global marking that is given in the end of exam. So one station, it didn't go well, it will not affect your global marking. But for 5 stations and all, it didn't like really didn't go well. Maybe like something really gross mistake has happened, or you didn't speak out at all, you went blank in the station. That shouldn't happen. So whatever is the station, old one, new one, it is something which you have never heard of. So we'll be telling you how to deal with such new stations also, like which just comes up in your exam. So how to go ahead with that. So at least you will be touching 2 or 3 domains correctly, and one domain getting affected in one station is still fine. But what I would suggest is the role players, if they are there, they are very much instructed to help you clear the exam. So just listen to them, what they are asking or telling you or guiding you through those points. That is important. Scoring everything, it is, if you are good in communication, if you know how to do your information gathering really well, if you're involving your colleagues, your multidisciplinary team, you're maintaining safety points, definitely you're going to pass this exam. So we'll be teaching you all those tricks how to deal with the domains also. Now, when it comes to information gathering, this is the general template that I'm going to tell today. What we can expect in general in any station. Not all the components are applicable to every station. We may have to skip some of these components when we are dealing with the different modules. Now when there is a role player, just introduce yourself. Like there, I would say like, hello, I'm Dr. Patil, one of the doctors in the antenatal clinic today. So can I confirm your name, age, and date of birth, please? She would say, okay, doctor, I'm Kelly, and I'm 32 years, something like this. So how would you like me to call you? She would say Kelly is fine. So why this is important? You should know how to introduce yourself. Practice this at least 5 times a day. You have to practice this. It should be in a flow. Information gathering, I don't want any one of you to fumble. It should be on tip of your tongue, and whatever questions are there, crystal clear, crisp sentences. Do not, use long sentences at all. There is no such things to use fancy words or anything. Just keep it very crisp, very short. Just say, I'm so and so in that particular clinic. I'm in gynecology or I'm in a post-op ward. So you should know situation awareness, where you are and what you're dealing with, whom you're talking to. But the good thing is confirm her age, name, date of birth, anything by herself. Don't just directly go and ask, okay, is this so and so? Sometimes there could be like you're not getting her name correctly. So let her tell what she wants to be called as. That is important. She would say, no, you call me Mrs. John. So instead of Kelly, you have to address her as Mrs. John in the station. So you should know what she wants to be called as. So just ask her, how would you like me to call you? Say Mrs. John. Otherwise, she would say, call me Kelly. Say that, okay, perfect, Kelly. I understand that you're here today to discuss about this something. Is that correct? Or you say that I understand that you had come to have some counseling regarding your pregnancy. Is that correct? So can you tell me more about that? What are your concerns? So put up an open-ended question like this. You let her come out with whatever she wants to talk to you. If it is your structured discussion, uh, I usually I never use the sentence like, I am one of the exam candidate and I've come here, because your examiner knows that if you're there in the circuit, it means you have come to give your exam. You don't have to tell that I'm the exam candidate, because nobody else moves in that circuit. It is only the exam candidate who is going to go from one chair to the other. So you don't have to go and sit in front of your examiner and say that I am your exam candidate. No, just say, if there is a examiner sitting over there, they would expect just a small greeting. So say that, hello, I'm Rashmi and I've read the scenario. I'm ready for discussion. That's it. Do not extend it more. You have read the scenario, you're ready for discussion. That's it. So don't say, I'm the exam candidate here. I have gone through everything. I'm ready for discussion. Do not use lengthy sentence. Just say, I've read scenario, I'm ready for discussion. Just wait. And your examiner will come up with the one, like, this is the scenario, or this is my first question. How do you want to deal with? Let's say, like, what do you think this case is all about? So they will start that discussion. They will open up that discussion with you. Okay. So introduction, no fumbling at all. Keep it really simple and practice it at least 5 times a day. And agenda is something which we tell our role player. For example, because we are meeting for first time, I can quickly ask you some questions to know more about you, and examination, if required, it will be done, because they'll give you the findings in between sometimes, or they have already given findings, then skip the sentence. And if you're examining, they would expect a chaperone. Chaperone is the one who assists for, it's a kind of nursing staff that they help you, and they are there. Their presence is required, especially if a female gynecologist is there, it's still okay. But if it is a male gynecologist, you cannot examine a patient without having a female attendant, right? So chaperone is a must, and they are very much essential whenever a medical examination is carried out. So make sure in presence of chaperone you're saying, and with the consent definitely, and run some tests if required. So this sentence can be skipped depending on the scenario, the situation where examination and all is not at all required. Do not use this sentence. There are situations where there is a lump in abdomen, she has come, there is mass that is palpable, and on feeling that you're getting that lump or the mass, it is freely mobile, some findings are given, and you just want to emphasize on that, or say that I may have to examine you later on. So you're not going to touch her during your task, but you can just say that sentence, okay, in presence of chaperone. And if required, only that has to be used. Run some tests if required again. Discuss regarding the evidence-based management options. How does this sound to you? So this is a kind, you don't have to tell everything. Keep it as a formal conversation. I don't want you people to memorize stuff, because in your exam, the role player, the scenarios may change. What questions have come previously that may not be asked by your role player. Trust me on that. It should be your presence of mind. Do not memorize things in part 3 exam. They are just there to guide you people, okay? You have your own style of speaking. Do not copy anyone. You have your own thought flow. You have your own kind of the style in which you speak. Keep it very simple, keep it very authentic. Try to deal with your role player in the way you are going to deal with them in day to day life, right? Never memorize anything, because if you forget even a word, you're going to fumble there, you get nervous, you get tensed. So just leave it off. Be yourself. That is very much important. Be yourself, be unique. Talk to your role player as though you're doing in your day-to-day conversation. Say that we are meeting for first time. Can I quickly ask you a few questions, and later we'll discuss the management plan. Is that okay with you? So just change your sentence. Just use them the way you are comfortable, but make sure that you're having that kind of fluency when you're dealing with them, right? And in the end, what you will be telling. So this particular paragraph which I have written, you can use it in the beginning or you can use it towards the end of your station. Sometimes um, I would feel that I may not be able to complete the task, so I would put up one or two sentences in the beginning itself. So let's say in the end, I'll give you some information, leaflets, and emergency contact numbers, and fix another appointment if required, and go ahead with the task. So this kind of, in the end, if you're not providing her leaflets or further information, or you may have to put her in touch with some specialist consultant. For example, she may require a fetal medicine unit referral. She may require a fertility center referral. So I would feel that I may not be able to complete tasks. So in the beginning itself, I used to tell these one or two sentences. So in the end, I'll give you some information leaflets and 24/7 numbers. If it's a kind of uh, term pregnancy or something, and we would feel that issue would come up in an emergency, give them these kind of numbers. Otherwise, say I'll give you information leaflets, and later on I'll fix another appointment if required. um, when it comes to open-ended question, as I said, keep it simple. Say, ask her, can you tell me more about your concern? She'll come up with the questions and all the information that has been given to her as a role player instruction. She will tell you. When it comes to HOPI, history of presenting illness, depends on the case scenarios that are there. So, if, for example, she has come with medical disorders, so she may be having some lung involvement, bronchial asthmas. She may be having some cardiac condition. She may have some kidney problems. So we don't know which exactly, like what scenario is there. So once you read your scenario, you know that okay, this is the respiratory system related. You have to take your HOPI towards that. Or she would say that I'm having pain, heavy bleeding. So your HOPI goes towards your gynec history, towards her menstrual cycle, how much she's bleeding, is she associated with, like, is it passing with the clots, how frequently she's changing pads, is it this affecting her quality of life. All these things, your HOPI goes towards that symptom. Once, if she has multiple symptoms, just ask her what bothers her more. Is it the pain factor or is it the bleeding? So she will tell, like, no, I'm more worried about my bleeding, because I'm staining myself or something. It's very much exhaustive, so she may have turned to be anemic. So just ask her, like, what bothers her more. That is the thing that you're going to address first, right? And menstrual history, keep it simple. If it is your gynec and menstrual related, then you're going to emphasize more on this particular history. But if it is not, then just ask her, can you tell me about your periods and when did you have the last one? Because you may have to offer a pregnancy test if it is more than 3 weeks plus, and she has not got her menses or she's not sure. It may be simple case of PCO who is trying for conception, and you will assume that 2 months of amenorrhea is related to PCO, and because she is trying without contraception usage, she may be pregnant also. So there are candidates who have failed to do a urine pregnancy test in a case of PCO who is trying for pregnancy. Everything else they have explained, management, but they have not offered a urine pregnancy test. We never know, she would be pregnant also. 2 months of amenorrhea doesn't mean that she is PCO and irregular cycles only, because she's actively trying for her pregnancy also. So offer her pregnancy test accordingly. And obstetric history, I always use the sentence, have you been pregnant before? I never asked, do you have children? She may be having a miscarriage, she may be having an ectopic pregnancy before. It doesn't mean that, only if she has children or if she's pregnant, she is going to have a child at home or something. So I always modified my question. I always asked the question as, have you been pregnant before? So if she says yes, can you tell me about your pregnancy? So she would say, okay, I had three pregnancies, two were miscarriage, one was ectopic. Now I'm trying for another pregnancy. I'm afraid that this will be an ectopic. Something she would come up with her story. So if you ask her, do you have children? She'll tell no. She'll keep quiet. And she'll not tell you about her abortions or miscarriage or anything like ectopics, nothing. So choose your words correctly. So just ask her, have you been pregnant before? If she says yes or no, something, then your next question comes up. In case if she is sexually active, so you can ask her like few personal questions. So are you sexually active? She would say yes or no. Then is she using any contraception? Contraception, especially if your scenario has young teenage girls or something like that seeking for contraception, or she has been using and it has failed, or she's been sexually active, she's not using condoms, so she may be used like barrier methods, then she would be prone for her STIs. So we may have to advise her that whatever method she's using, for example, a copper coil or something, also she has to um, continue to use barrier methods also to prevent her STIs. So these kind of advice, as and when we are dealing with the stations, we'll be telling you also. So if she's using a contraception, just kindly make a note of that, or if it is relevant to your station, then only ask this question. STI history, it's my duty to ask sexual health, or you can ask few personal questions, may I? And just go ahead. So have you been treated for sexual infection in the past? So she would come up with those kind of information. Cervical screen, have you undergone cervical screen? Were they normal? Keep it simple. Cervical screen question, you don't have to ask in many of the tasks also. Where it is relevant, please do ask. Delivering patient, you're not going to ask her about what about your cervical screening, has it been normal? So the scenario would be your discussion about her second stage cesarean versus instrumental delivery, and we are not bothered about what her cervical screening was. So don't ask such irrelevant questions in this station. But if there is a scenario where a CA cervix patient has come and she is pregnant and she wants to discuss mode of management, definitely your screening and all is important there, but not in irrelevant stations. Medical history, keep it simple. Do you visit your GP for any condition? Are you on any medications? Allergies, if are you allergic to any medications, metals, substance, food? You can combine these things, because there are scenarios where there are penicillin allergy, trimethoprim allergies, nickel allergy can be there, latex allergy could be there, allergy to egg, peanut, all these things can be there. They can be allergic to an extent where they had anaphylaxis or they have recovered from that, and they carry this adrenaline shots with them. So general question is, are you allergic to anything at all? Or are you allergic to any medications, metal, substance, food? You can just ask that way. Or are you allergic to anything at all? So she would tell like what substance she is allergic to. Surgical history. Have you undergone any surgeries on your tummy down below? So keep it simple that way. And past history, if required. For example, she is having bronchial asthma. So you are asking whether she is previously hospitalized any time, or she is a known case of cardiac condition. She has deteriorated, or she is inflammatory bowel disease. Her condition has been unstable in the past. Now it's all fine. So any previous hospitalizations can come up there. Uh, then there are social habits. Do not hesitate to ask these questions. So there are candidates who are putting lengthy, um, kind of sign posting. What we say means we indicate the role player that we are going to ask something personal or something which is not expected from them, or something that is called as a sign posting. So do not do lengthy sign postings in your information gathering. Keep it very simple. In UK, they are very much open to questions like smoking, alcohol, sometimes recreational drugs they may or may not take. We don't know. But do not feel sorry for asking these questions. I always say that this is your job. You're sitting there to take that information from them. Why you have to feel sorry? So you just have to ask few personal questions. May I? Do you smoke? Do you take alcohol? Do you take any recreational drugs? So don't say like, I'm so sorry, please pardon me. Do not, just keep it very simple. So few personal questions. May I? Or you can ask few personal questions on life, like, social life choices or your lifestyle. Keep it simple and then put up your questions. uh, Smoking, they may be, there are smoking cessation service, the NHS stop smoking service is there, you can refer them. But as and when, just say that smoking can cause ill effects on your general well-being also. So would you like to consider to stop smoking? She would say yes, maybe in the future. Then if you're okay with that, I'll connect you to NHS stop smoking services. Or consumption of any amount of alcohol is generally not advised during pregnancy or when you're planning for pregnancy. So, would you like to stop taking alcohol? So, you just ask them like that. And recreational drugs, they may not be taking, so just extract that history from them. Do not put up lengthy signposting questions, nothing. Just say a few personal questions, start asking your questions. Family history may not be important in all, but if you have to extract family history, where it would be, maybe she's a diabetic patient and she's planning for pregnancy, or she's having family history of diabetes, now she's having deranged sugars, you want to explain, or hypertension that runs in the family, that could be there. Then there are scenarios where there is cancer history in the family, those stations you ask. But there are bipolar disorders, the patient is on lithium, then we are extracting other histories. Or there is a case where the patient is having postpartum depression and you extract the family history that mother has a bipolar. So there it becomes relevant. But when again I say post operative care, where the patient is having bowel injury, she's lying on the bed, she's undergoing complication and treatment for that, their family history of diabetes, how is it going to matter? Their the family history of cancers is not going to matter. She's worried about her bowel injury that she had or the ureteric injury that she had. That is your case. So do not ask such irrelevant questions in your scenarios in such modules. So you have to be very choosy, very particular, filter out all these things from your station. Social history may not be relevant everywhere, but if you are extracting what information you're looking for, what do you do for a living? So she may be a kind of horse rider or something, or and you are dealing with a case of placenta previa. There we are worried that if she continues her job, then it's a kind of the aggressive moments or something that may trigger a bleeding episode for her. There it may be something which is important, or you may have to know that what kind of financial stability or whom she's living with, how is the support at home, is there any domestic violence that you're looking into, so how is your partner, is he supportive, is she safe and happy with him. So NHS has a system that every pregnant woman, you have to rule out domestic violence that is happening, because it's quite common over there. So we should make sure that our role players, they are safe, the patients are safe over there. So how can you ask that? You can just ask, what do you do for a living? Whom do you live with? Are you safe and happy with your partner? So keep it simple. Is your partner supportive? So do not ask two, three questions which would lead to one answer like, yes, I'm safe, or yes, I'm happy. So I'll not ask how is the support at home? Is your partner supportive? Are you safe and happy with him? And look at the role play for the answer. No, just ask one question out of these. So, what do you do for a living? Whom do you live with? Are you safe and happy with him? So, these three questions are enough. Do not ask how is support at home. Is are you safe and happy with your partner? Both the things are going to mean the same. So, just choose one question. Ask that. Rule out domestic violence in UK. Mental health. Have you felt down, depressed, or anxious in the past few weeks? So, do not label it as 2 weeks, 4 weeks, 6 weeks, 2 months, nothing. Past few weeks is sufficient enough. Have you felt down, depressed, or anxious in past few weeks? Blood group. Are you aware about your blood group? Any reservation for blood transfusion if need arise? and ask this question only when you're talking about blood transfusion. There is a PPH, then you're anticipating there is a placenta previa, you're anticipating a blood loss. Suction evacuation for molar pregnancy, you are anticipating a blood loss. So those situations, or she is severely anemic and then you're thinking about blood transfusion for her, or you're thinking it's a high risk case and then you're reserving blood for her if required. So those are the scenarios. I am not worried about any particular like pre-menopausal something she has come up with the PMS symptoms or something, or she has come with postmenopausal hot flushes and there I'm worried about blood group and transfusion for her. No. So those stations we are not going to talk on the blood group reservation for blood transfusion. But yes, antenatal care when they are coming and you're thinking that the scenario would require blood group is essential there, right? And reservation for transfusion you're asking in scenarios where you're thinking that you're going to transfuse blood. They could be twin delivery. We may expect PPH for them. So in those scenarios it is still okay. So you can ask those questions there. Because there are people who follow Jehovah's Witness and they do not accept blood or blood products. There are alternatives available for them. So we may have to filter out or figure out, and if they want further discussion on them, then we can do it in the subsequent, like with the questions when we are dealing with them. Now, BMI, very much they are aware about what the word BMI means. But if you really want to tell something, it is the weight to height ratio called as BMI. So are you aware about that? So if they say that, yes, I know, and my BMI is 42. So we are not going to directly tell them that you have to exercise, you have to lose your weight, you do the dieting also, and then cut down on your weight, all these things. We are not going to give that advice then and there. They may get really angry, furious at you, and they are instructed to do that in your exam. So what you're supposed to do, be smart. Just ask them, is it of a concern to you? Does that bother you? One question you ask like that. Okay. If she says my BMI is 42 or something, just ask her like, does that bother you? She would say, no, doctor, I'm very much happy with this. Then don't deal with that question then and there. Leave it off. When you're explaining things in your management, just say that women who had a high BMI, when they lost some pounds, so they have seen that their symptoms improved and they are able to cope things better. Would you like to consider losing some pounds? Then she would say, like, okay, it has helped them. Maybe it'll help me also. But if you say then and there in the beginning that, okay, I'll put you in touch with dietitian, some physiotherapist, some exercise or some, start working out, she would say like, I'm not bothered and why are you telling all these things to me? How is it going to help me? So without management, and how is it going to be beneficial if you're not pointing out in the management points? Don't tell her in the beginning. She may get angry and your entire station, it gets stuck at that point, explaining and calming her down. So just carry forward with your station. Just ask one question. Does that bother you? Or you can ask her, is it of a concern to you? She may tell yes or no. If she says no, don't deal with that point there. Take it towards your management. Give example of other women where it has helped them, and then you come back to this. So I'll be dealing and I'll be teaching with high BMI stations also. There I will tell you how to handle these things smartly. Towards the end, when you're summarizing thing, I never summarized the information given to me by my role players. Some candidates may think that, okay, summarizing can help, but it is again individual choice. If you have a good amount of time left to summarize things, you're okay, do with that. If not, then leave it. It's not going to add much difference to your station. So to summarize, not to summarize is personally your choice. I never summarized in my exam and I've cleared it in my first attempt. So it doesn't really affect the way you're doing things, right? You don't have to tell all the points again. So here you are, 42-year-old, you have come with this symptom, you are having this condition, your hemoglobin is this, nothing. Just leave it off and say that, is there anything else that you want to add or that is important for me to know? Is there anything else that I've missed asking you? So put up one question like this, any one question you can choose out of these two. She will tell, okay, doctor, I forgot to tell you. Or she would say that, doctor, I also wanted to discuss these things with you. So she may come up with some missing information. And based on information, I can offer you some evidence-based management options that are available for you. And together, means you and I sitting together, we have to arrive at a mutually agreed, it is both of them has to be satisfied with that particular option, right? Safe management plan. which is acceptable for you. So she has to agree upon that. It should be safe for her. It should be acceptable for her. It should be mutually agreed. And you are giving evidence-based management options. What does that mean? You're telling the management options that are there in your guidelines. So that is the evidence that you have. So, Kelly, based on the information that I've gathered, I'll be giving you certain evidence-based management options, and together we can arrive at a mutually agreed safe management plan which is acceptable to you. So you have to discuss all these in management options there. So I will also tell you how to discuss or how to start the management. How do you close the information gathering? So just say I've given a lot of information here. There are leaflets that are speaking about what we discussed, and I can put you in touch with some support groups. For support groups, what do you mean? Like there is Down Syndrome Association. So there are the mothers who have had Down's babies, and they are discussing amongst each other how to cope up with the children, what they can do so that their life becomes better, how emotionally they are supporting each other in their discussions. They can speak openly about their experiences that they have, and they share their things with each other. So it's a kind of a support group that they have. So NHS has a lot of support groups in that way, where people with similar condition, they come together and they discuss. So they are able to help each other. So they feel that you're not alone. There are people, other people who are having similar things, but they can also give you encouragement that how they dealt with that, and how everything they are managing smoothly. So these Down Syndrome Association will help them deal with all the Downs babies also. So mothers who are having a high risk for Downs, if they want to have some discussion, or they may not be able to take a decision to end the pregnancy and they want to continue and give birth to a child, but they are not aware about how they're going to deal with that later on in their life. So they just go there, they talk to such mothers, they see Down babies, and they see how they are doing. That gives them a kind of insight. So these support groups, they really help each other in dealing with that situation. So support groups are different. They do have different names and all in NHS. If you remember, you tell. Otherwise, just say it's support group. That much is sufficient. So I have given a lot of, and there are some handful of support groups which are very much essential. Like as I said, Down Syndrome Associates. It's a very common, a support group where, and common scenarios in your exam station where you have to deal. So you can remember such important support groups only. Don't, if you do not remember, also just leave it. You can just say, I'll put you in touch with some support groups for your help. And if required, your consultant is not there and you are replacing your consultant in the discussion. So if your consultant is not there, before you start discussing with your role player, just apologize. I'm sorry that my consultant had some was stuck in a work or something and wasn't able to attend your consultation today. Is it okay if I take forward your consultation? I'm Dr. Patil here, one of the senior doctors in the clinic or something. So you take a permission and then you start. But in the end, make sure that as you wanted to meet consultant, so I can schedule another appointment with him or her in the next meeting, so you can discuss your further concerns if anything are there. So you put up another appointment wherever the scenario is there where your consultant couldn't come and you are replacing. And there are specialists, as I said, epilepsy person, then it could be a cardiologist, it could be a fetal medicine, fertility. So you may have to fix another appointment with them. So if your scenario demands that, you do that. And emergency numbers, in case if they require, you can provide. If any queries you have, you just say that I'm happy to clear. So any other doubts that you have. So she would say like yes or no. And if you have some time, use sentences like, me and my team of doctors are there to help and support you in this. If any doubts, anything you have, do let me know. I'll be happy to help you. So in those situations, you can tell that. And thank you for your time. And then you end your station. So this is how the general station would go. And few points about communication with patient or the relatives if you're dealing with. This is very important domain. Introduce yourself, never forget who you are, right? And know where you are. You're there in antenatal clinic, you're in OPD, you're a gynae clinic person. So you should have that awareness where you are, and know why that role player is there. She has come to discuss a pregnancy concern. She has come to discuss about bleeding problem. She has come to discuss about hysterectomy. So basic scenario would explain that why your role player is there, and tell her why you are there to deal with her. The voice tone, as I said, please practice, practice, and practice. Be genuine to yourself. um, the way you're speaking, that much is enough. Just the tone adjustment has to be done. Make sure you sound correctly for that scenario. Be it any patients that you're dealing with in OPD, or be it your nursing staff who is there to help you, your junior colleagues, anybody, your relatives, your family members, your friends who are there, just try to practice these stations with them also, and just ask them like, do you feel that this kind of, the voice that I'm dealing with, so in sensitive scenarios, cases and all, how it would sound. You can record your own voice and then listen to that. So do you feel that you're sensitive enough towards your role player? Have this practice of a good tone, and you can use it in your day-to-day basis also, in your hospital setup, in your house, everything. Just maintain that soft tone in your voice. But soft tone doesn't mean you are compromising on the speed that which you're talking. So as I said, speed is equally important. Do not just rush with your sentences, but yes, have a good speed, a good tone. Try to connect with your role player. Just imagine that they are there in your real life scenario, and try to keep it that simple. Okay? Keep it as a conversation. Never memorize things and come and speak up sentences. That's not going to help in your part 3. You will fumble up, you will go missing, and you will get panicked in your station. So never do that. Just be yourself, deal with them, talk to them as though you're dealing in your day-to-day basis. Signposting, something, as I said, you're giving a warning shot that you're going to give some bad news, be it a breaking bad news station, negotiation station. For example, as I said, like second stage cesarean versus instrumental delivery, you're trying to negotiate between the benefits and the risks that are involved, explaining the condition to them, what they have, discussing about mutually agreed plans. Angry patient, sad patient, upset role players. The relatives could be upset because the wife has suffered something, so husband is angry in that scenario. It could be anything like that. Listen to them carefully. They may be giving certain cues which you have to catch, and you that will lead you to those important pass points. Debrief is something where you're explaining a scenario, you're dealing with a role player, and you're debriefing about the situation that has happened. Duty of candor is being apologetic, that being open and honest with your role player about explaining things. So that is called as duty of candor. Avoid medical jargons or abbreviations. Do not say that you have a PCO condition and your PCO is like this. Say polycystic ovary, and then you go ahead. And do not use medical jargons in front of your role players. You can use some common layman terms, and give information in chunks. So once you start your station, do not speak continuously for 4 minutes. Don't do that. Give small information, check understanding in between. Just ask her, am I clear so far? Any questions that you have? Do you want me to explain anything further? So, any doubts? Anything like this, one question you ask like that. Am I clear so far? Just practice that. And maintain your body language. That is very much important. Uh, there are candidates who have the habit of moving their hands too much when they're talking to somebody, or they nod their head too much. They entirely shake their body when they're nodding their head. Try to have that self control. You can practice in front of a mirror and see your response, how it is. So do not nod your head too much. Just a slight nod, that should be sufficient. Please look after your hand movements. Do not move too much of hands like this. If you feel that you're moving your hands too much, just keep it low. Just keep your hands stable, one hand over the other, and just try to maintain yourself calm. Let the role player make the decision when you're giving an option. It could be irrelevant, and she would say, like, there is meconium stain, and she would say, like, I don't want cesarean at all. There could be pathological CTG. She'd say, no, I don't want. You deliver me normally. So it's a sound decision for the baby outcome also that she has a cesarean at that pathological CTG. But if she's saying, I do not want, just explore the reason that why she doesn't want. Is there anything that bothers you? Like, what are your thoughts about cesarean? So she must be skeptical about certain things there. So just try to find out that what is the reason that she's so much adamant about that decision, be it not in her favor, not in baby's favor, but why is she doing these things? So try to explore that reason. She would say, no, doctor, my sister had cesarean and she had a bad wound infection. She had a lot of complication. She had some injuries. She had some tears, the wound gaped up. All those things she would say, and I'm very much scared to have cesarean. So tell her that I'm so sorry that this has happened to your sister, but not every situation is the same. I'm not aware about what the situation or scenario was there that time, but I can assure you that your case is going to be dealt by experts, and we'll make sure that the such thing doesn't happen to you. So try to explain and calm her down that what fear she has. Try to explore that reason. But let her make that choice. You're not telling no, this you have to undergo cesarean because the baby would be in danger. You are not doing the decision making. She may be having even precedentia, but she would say, I don't want surgery to for this. You may have to give her pessary. You may have to discuss other things, but she would say, at no cost, I will remove my uterus. So you have to explore reason. Let her make a choice, but your job is to give her the options which are evidence based. Right? You tell her, like, what are your thoughts? What do you want to go ahead with? And let her make a decision. So have a good supportive ending. If she's still in some confusion or something like that, give her some time. Say that, okay, I'll fix another appointment. Have a word with your partner, have a word with your family members or friends, and then we can have a discussion again. So you give her that particular time to think and come, and give her information leaflets for further understanding. Tell her about support groups if she wants to talk. The next aspect is about communication with your colleagues, and all this is also very important. As I said, NHS works on multidisciplinary team approach. They are nothing but the team of specialists that are looking into. They could be doctors, nursing staff, paramedics. They could be some other health professionals, physiotherapists, dietitian. So other members everywhere, not merely the doctors, but entire team who are going to help them manage the case. And remember, you are ST5. We may be a consultant at our own place. We may be running big hospitals. We may be the professors, HODs, or anything a higher position in our career. But for MRCOG Part 3 exam, we are all ST5. We cannot handle certain complications at ST5 levels. If there is a bladder bowel injury, we are calling specialist. Small bladder injuries and all, we may have closed ourselves during our surgical times, but when it comes to exam, we are ST5. So remember that you are ST5. Do not talk to your examiner in terms of that, I will take this, I will suture this, I will handle this, I will do this. Call specialists who are there, call your consultant, and this it has to be repaired by the specialist there. And if your consultant is trained to do that, yes, but if your consultant is not, they are not trained in urogyne, then a urogynecologist or a urologist has to be called in who are trained in that. Involve seniors, involve your specialist. S bar is something which is a tool used for effective communication. What does that mean? SBAR means a situation, background, assessment, and recommendations that you do in that particular scenario. So here is a situation where a pregnant lady has come, and she has a background history of hypertension. She has been on these medications. On assessing, you feel that the uterus is tonically contracted or something. You feel that there's an abruption. So my recommendation is immediate stabilization and arranging for a scan to rule out abruption, informing my seniors, calling in the team. So this is the scenario, the situation, what is the background, what is our assessment, what are your recommendations. So you have to use this kind of communication. So this is a tool. SBAR format is what we say. If you're talking to somebody over phone, like this we do on day-to-day basis with our seniors or colleagues or something, we tell them the scenario, we tell them what is the background history, we tell them what are the findings now, assessment, and we tell like, okay, these things are being planned for her. So what do you think? So these are the recommendations that are there. Referrals, especially like, uh, specialities that we need to send them. So you may have to write a referral letter. So say that, okay, we'll be giving a referral letter for the same. There are teaching stations also. Previously, Osler system, when they were there, they were not involving much of the mannequins or something because it was just an online exam. But now it is completely face to face. So you may expect a mannequin station, you may expect instruments that are given to you. You may have to hold them in your hand and demonstrate and show. There are scenarios where you have to draw on a paper and show it to the junior that how it has to be done. There can be some skill demonstration stations. So the best thing is, in your workplace, use these things and start teaching your juniors, your nursing staff, just 10 minutes. That's it. After that, again, you ask them to do it for yourself. So you're getting both the benefits. They are also getting a skill transfer. You are also becoming good in your teaching stations. So involve your juniors, try to practice with them all the teaching stations. Practice with your study partners, do some case-based discussions also. And OSATs are something which are signed. So these are the assessments that are being done. There are formative and summative sets. Formative means you can collect them any number that you want. So, for example, episiotomy is going on and you have observed them and you have sutured it under supervision or something. So, you're collecting your assessment forms there, and some advice will be given by the person who is observing you. At least, like, one consultant should give you a sign off for your summative assessment, the OSAT over there. And your formative assessments, these are not your judging things. Your summative would be that you're skilled to do that particular procedure. So at least three summative if you collect, one should be from a consultant. And according to the metrics, it is ST6 and above. But what NHS generally what they say is, even if it is a minor procedure, even an ST5 can sign off if it is just like episiotomy or something like this and you're teaching. Not a second degree, third degree, I mean, not a third degree and fourth degree tear, but something like a small episiotomy and the suturing that you're telling. So this can be signed off, but at least one sign off should be there from a consultant. That is mandatory. So these are the assessments that teaching stations may demand. Speaking about the patient safety, as I said, confirming name, age, date of birth, or NHS number on the details that are being provided. Check the details on the reports. Rule out allergies. Jehovah's Witness, as I said. Mental capacity. So, 15-year-old girl, she has come to ask regarding termination of pregnancy. So, you're explaining all those things. You're asking her about whether she has understood all those options or not. So, you're judging and looking into her mental capacity. Safeguarding, especially when child is involved in something, and you want to involve the child safeguard team over there. So there you will be involving the safeguarding points. Next is about the LMP and ruling out the pregnancy. Examination in presence of chaperone with her consent. That is also an important safety point. Taking a verbal consent or a written consent depends on the scenarios. Keeping a good swab count is essential. It is a never event. You should not forget your swab anywhere, like vaginal swabs, abdomen surgeries. You're not forgetting any swab there. Gum clinic. This is the genitourinary medicine clinic where any infection screenings, everything happens, and you are sending them, referring them to rule out other infection, and they also notify the partners to undergo the testing if they have certain swab positive over there. And call for help whenever you require a consultant help. Please involve them. Involve the other staff. Like there are stations on labor ward prioritization. You need to involve your team. That would consist your midwives, the nurses, there are stations on gynae ward prioritization where other specialists may be involved. So you have to involve your team as such. Medications, dosages may be important in structured discussion, but don't have to remember everything. Suitable contraception, which is best for them. Like molar pregnancy, we are not going to keep something intrauterine device. So you have to avoid that. Though that is a we have to think about the suitable contraception and then advise. Enhanced recovery program. I suppose all of you have gone through that in your part two also. Part three, it is important. These are the programs where it is nothing but the patient is involved in her own care plan. It starts at the ground level, that is a community GP level, and then it comes towards assessment, improvising, optimizing her conditions, improvising hemoglobin, maintaining sugars, maintaining blood pressure, making her fit for surgery, during surgery and post surgery, how steps are taken to have a faster recovery. All these things are the ERPs. And WHO safety, like surgical safety checklist, we all know about that. This is very important for part 3 also. uh, there are certain clinical governance points, what we say, like maintaining confidentiality, debriefing, being open and honest with them, that is a duty of candor, having good documentation. This is very much essential to avoid all medical legal cases and all. If you have documented things really well, this is important. Even whatever you are discussing, also you can just document the discussion on the notes. And DVT risk assessment, every patient, we have to make sure that this risk and all everything is assessed properly, and accordingly the blood thinners are offered. DETICS is nothing but an incident reporting, online incident reporting that they do. We have gone through the incident reporting for the part 2. There's a table, beautiful table given. So not all scenarios would require that, but there are gross things like, some negligence happened. A newborn got admitted to NICU, like the term baby getting admitted to NICUs, or there are bowel injuries that has happened. So return to the theater are there, PPH is there. So gynae surgery is also, a lot of blood loss was there. So there you have to raise an incident report. Third degree, fourth degree tear has happened. So already the incident report has been raised and the team is looking into this matter, the result of which will be conveyed to the patient again. And discharge summary, it is a legal document, so it has to be written properly. And if any doubts are there, have a discussion with the senior also. And risk management team is something which, where something goes wrong or in the hospital, they just evaluate the scenario and see if anything, what went wrong in that scenario, what could have been done to improvise things, or prevent such things from happening in the future. So risk management deals with that. And the outcome of this risk management, everything is conveyed to the patient also. Like, okay, we studied this and this is the final report, and that has to be submitted to the patient also. PAS is a patient advisory license service where you are reporting something, you're upset, angry, and you're raising a complaint officially. So PALS team is going to look into solving that particular problem. Now, when it comes to applied clinical knowledge, yes, all of you have a strong knowledge. The GTG is nice, talks, PASH, FSRH, sign, FIGO guidelines, everything have been studied in the part 2. Do not read page to page everything, word to word, everything from the guideline. Just basics, and especially the management, I would say, brush up only those things. But one quick look into the guideline is required. Do not sit and memorize each and every percentage that is given. It's not your part 2. Just have a strong base and make sure when you're explaining things, be it history, investigation, blood, urine, imaging studies, anything, just justify. We'd look into your hemoglobin just to rule out any low blood levels. We want to rule out infection, so full blood count is done. We want to check the urine to rule out any infection. We want to do the scan of your tummy to see if there is any concerns, or see rule out any fibroids. So you are justifying that why you are advising. So when you're explaining, just make sure you're telling and justifying your things, and have a structured approach and put a skeleton of your management. This I tell all my candidates, the moment you start discussing management, you put up the skeleton of management. Why? Because later on you may or may not be able to complete your entire management, but your role player examiner knows that yes, she also spoke about surgical management in the beginning, right? So explain everything and let the role player make the informed choice. It has to be evidence based. Now, what do I mean by skeleton of management? For example, you have to divide it into two things first in your mind: the clinical management that you're going to talk about, and the clinical governance point that you're going to touch. What did I tell about the clinical governance? Debriefing, duty of candor, documentation, discharge summary, all those stuff, DATIX, raising an incidence report. So not everything fits into all the scenarios. Again, you need to filter the clinical governance points. Okay, some station will require only documentation. They don't have to do anything else only. So just say I'll be documenting our discussion in the notes. So some will require incident reporting. So some will require debriefing, some you have to perform duty of candor, be open, honest, and accept the things that have went wrong. So your clinical governance, again, you need to filter. What comes in your clinical management? It can be expectant or conservative or lifestyle that you may have to talk about. It can be medical or it can be surgical. In surgical, it can be again conservative or definitive. So try to put these flow charts in your mind, how you are going to explain things to your patient, your role player who is sitting there. So in the beginning, I'll be discussing few clinical management and few other points. Then I'll be speaking about some lifestyle changes, some medical options, and some surgical treatments that are available. My role player said, I don't want surgeries at all, doctor. So she ruled out one particular limb of this management for me. I was happy. Okay, come on, let me talk about lifestyle and medical only. So she said, like, okay, so let me talk about this and this. So then I started explaining. So she immediately said, I don't want surgeries. So why would I say that no, no, for your condition, surgery is the best. I am going to talk about surgical first. No, take it stepwise and tell. Then, okay, this is your condition, this is your prolapse, these are the things. So they may tell you, like the other person will tell you, doctor, I don't want to try all medicines. I have tried some and it didn't benefit for me. I just want to get rid of this condition. Just do, means she wants some surgery. So don't go on explaining other stuff. Maybe lifestyle is required for her enhanced recovery, the BMI control or something. It may not be necessary for the managing that problem. It may help her optimize for the surgery. So you may have to tell lifestyle also, but medical line, then don't speak much about that. Say, okay, these are your surgical options. Think about laparoscopy, think about open surgery, think about conservative surgery, think about definitive surgery that you're going to offer. So your limb of management is going to change. So just ask what her priorities are and then you explain. So now that you know your domains, everything, you have to start your preparation for the exam. Start performing the stations very much required in our Telegram groups. So the more you are submitting, the more you'll be getting feedbacks and more stations are going to get allocated for you. As soon as you're submitting your task, the next task will be allotted and you get a time. I would suggest like at least daily one task submission has to be targeted to keep these things ongoing, to keep the practice ongoing, very much essential. So start performing the station, collect quick informations, collect about the HOPIs, do the signposting, summarizing. So there are a lot of voice recordings that have been put up also, which can guide you through the stations. Summarize may or may not be required. Examination may not be required in your station. Investigations, justify them. Clinical management, check understanding in between. Once you told lifestyle, just ask her like, am I clear so far? She would say yes. Okay, speaking about the medical, there are two types. One is a hormonal treatment, one is a non-hormonal treatment. This would include these, this would include these. Am I clear so far? She would say yes. Okay. Then comes the surgical options that you have. So these are the surgeries 1, 2, 3, 4. So explain, check understanding in between. Just see whether she's understanding. Don't go on speaking management for 5 minutes and she would say, like, doctor, I didn't understand anything what you said. And you'll be like, okay, which part? She say, I just understood lifestyle what you said. After that, I didn't listen what you told. You didn't check understanding anything after that. She didn't understand your medical line and you have finished your surgical options also. So check understanding in between and involve your multidisciplinary team. That is very much important because you're ST5 in your exam. Clinical governance, just touch few points. Give information leaflets, write back to GP. GP usually sends some referral letters if they have come through them, no? They send the referral letters. So you have to address and write back to the GP telling about what things you have discussed and what plan you have made for that patient. So write back to the GP again, MDT approach, involve them. Consultant, if appointment is missed up something, then you have to give another appointment with the consultant. Hospital numbers, as I said, a follow-up or next appointment has to be scheduled. So your exam is going to be face-to-face exam. RCOG always wanted part 3 to be face-to-face, but because of the COVID reasons, they had converted it into online exam. Then it became hybrid. Now they have totally converted it to face-to-face exam. There are 14 stations. Give your best performance in each and every station. If one station goes wrong, don't worry, you have 13 more to go. If two are also long, leave it off. You have 12 more to go. Give your best in every station. Maybe it is the last 3 or 4 station where you know everything about that station and you have to give your best performance, but you're exhausted by that time. Don't let those things happen to you. Keep equal enthusiasm in every station. Just go on performing every station, take them one by one, give your best, and have a smart approach to your station. Don't keep on telling long, lengthy stories and sentences to them. You should know how to pass every station by doing a smart approach to that particular station only. Hard work, definitely it helps. Smart work is going to add on things to you. Be dedicated to your group, submit everything correctly, put on your efforts. We are also there putting on our efforts to help you in this exam. Okay, be confident, be smart, try to apply whatever you have studied in your part 2 here clinically. Start studying with a strict study partner. Involve family members wherever you feel that they are helping you with. There can be friends and colleagues also at your workplace. They can help you. The best ones are your real patients. Your OPD is going to run faster when you're finishing each and every case, or the OPD is in 10 minutes. So definitely it's going to help you all also. So use them as your real patients and try to extract that information in 2 minutes. Try to explain things in 10 minutes and try to target that as 9 only. Give an extra grace 1 minute for yourself. Use nursing staff, use your juniors for teaching stations. If nothing is there, mirror works. So just stand in front and see your body language, see how you're going to communicate. And we do offer one-to-one station apart from the regular courses. So if anybody wants some extra help or something, then one-to-one stations are also run by mentors. Never get exhausted in this preparation. Trust me. Each and every day is equally important. Don't get exhausted. At times you may feel that don't have energy something, but just push yourself hard. Okay, today one task at least I have to submit. Towards the exam, start practicing mocks. That is taking things in a stretch. Maybe 3 station, 4 station, then you're speeding up to 7 station in one go. Improve yourself to 10 stations, then 14 stations at least. So try to do stations together. As and when the exam is approaching, the number of stations that you're clubbing and performing should go on increasing. You can do it yourself when we also run mock circuits, so you can take them towards your end of preparation. Take off from work if required, but it's not mandatory. There are juniors, there are students of mine who have worked even before the exam also. The day before the exam, they have done their duties, come back because they felt that if I'm sitting at home, I'll be more tensed. There are people who have taken a month off, 15 days off, everything is acceptable. Whatever suits you the best, please do that. Do not, overburden yourself. Do not say that, okay, she is taking off, so she is going to study more. I am working here, I am going to be less. No, because you may be doing your day-to-day scenarios and practicing station at your workplace itself. Why do you have to sit at home and do everything alone? Go outside, practice, use those live role plays that you have there. Patients are there, you talk to them, you perform your task in front of them. So off from work, you're taking, that is still fine. If you're not taking an off also, please make good benefit of that opportunity of practicing your stations in your workplace. Family commitments can be there if there is help available, relatives, your family members, somebody can come and help you out during the exam hours. Do not hesitate to take help. Practice reading fast. It's very much essential. And similarly, writing on the notepad only the bullet points, okay, that you want to speak. Do not write sentences. Do not waste time. You have to read and absorb that scenario. So write only bullet points on your notepad. Try completing your task in 9 minutes. Be perfect, be fluent, be confident. From the beginning till the end, you have to be confident. Give a very impressive ending to your role players and your examiners. And the way you are going to start your station, end your station, it really matters a lot. So let's start the journey. You should know your mentors. This is me, Dr. Rashmi Patel, and this is at convocation in UK, February 2020. So I cleared my exam in November 2019, and following which I attended the convocation ceremony in February, and after that there was COVID and lockdown, so exams didn't happen, convocations didn't happen. I was just lucky enough that once I landed back in India, after a couple of days, there was complete lockdown. Dr. Geetika Arora, she's from Delhi, so she'll also be dealing with the part 3 sessions. Dr. Siddesh Iyer, he's from Mumbai. He is urogynecologist and is also the RCOG examiner for your part 3. Dr. Rupali Bansal, she is from NHS. She'll be dealing with the clinical governance session for all of you. And we have to have a comprehensive approach. That is your first step. We'll be having 15 live sessions which cover 90 stations with detailed explanation. I take only 6 candidates in one batch so that all the 6 candidates get one task in every session that we are performing. So I want all of you, if any candidate is absent or something, the other candidate gets an extra chance so that which can get compensated in the next subsequent session. So I'll make sure at least everyone has to perform one task, and any additional, if anybody is absent also, the colleague compensates for that. Every candidate should perform. It is only when you speak, you open up your mouth, I'll be able to do the corrections if required. So it is very much essential that you have to speak. Part 3 is all about speaking. It is not listening to what others are speaking. It is you who have to come. So that is why I do not believe in having a listeners batch. So you have to be active participant. Some will, you will listen to other people speak, but if you are not reproducing that, if you are not speaking that, what is the use of listening to even 100 tasks that are done by others? No, you have to perform, you have to speak, you have to tell your, the sentences in your own tone, in your own best, the way that you're talking. So you have to do it yourself. Only when you talk, I'll be able to do some corrections if it is there. I'll be telling. There are instances where my candidate is just like, she was going on talking in a monotonous way. I said, no, it's not the way. You just lower down your tone a little bit. You have to modify. And she's like, no, yes, ma'am. I said, like, yes, this is a tone in which you said, yes, ma'am. So please use that tone. So the way she improvised, it was just like, tremendous improvement. Within a span of a month, she became an expert in handling such difficult situations. So the first task, which even she would say like, the I when I hear myself, it is completely different from what I'm performing now, madam. So that is the thing that comes out only when you speak. What other people they speak, listening to that, yes, it gives you an idea. I do agree, but you cannot say it in the same manner. You cannot reproduce it in the same manner, and you may fumble up. You do not have to memorize things. That's what I say. You have to practice. You be like, spontaneous there. And Telegram course groups are there where we start solving the practice books. Unlimited task you can submit. You can submit one task, I give you the next task. You can submit it the same day also. You can submit the next day. But I want that practice to be ongoing. How many tasks you're submitting, we are ready to give the feedbacks. So that should be your target. There are instances where the batch has finished all the 4 books promptly, and there are instances when they were submitting, all the 6 candidates were so active, they are just covering all the books and the papers then and there itself. So it is very much essential that I want all of you to actively participate. The remaining 5 sessions, which are there for the long course. So the regular course has only 15 sessions. The long course, they have the benefit of 5 more sessions. These are the mixed bag sessions where we will be covering 12 stations in one session. So another 60 stations are added up for your people, and candidates have to practice how to cover management of each of these stations in a very rapid way. These are the sessions that are taken closer to your exams so that you are very much well prepared in dealing with every station. Telegram course group, again, you have to do the daily submissions. Circuits, what we run, that is towards the exam. So we do give discounted offer for our registered candidates, and 14 stations, every individual person you can, like, candidate can perform. It's kind of a real exam scenarios. Online stations, we do have certain on-site programs also with that details and all will be coming up later. But the online circuits which we run, it is very much, except for the mannequin stuff and all the remaining everything that we are doing, it's very much an exam like scenario, and a detailed feedback and fine tuning is done. Speaking about the library access, which will be given to all of you, the voice library has more than 500 plus recordings. These are all arranged module wise. Why the recordings are there? They are there for you people to listen, see how your seniors, everybody have performed. It's not the same way that you have to memorize things again, I would say, but they are just there to guide you people, just to see how things are done, but be unique in yourself. You have to have that your own style. Then there are practice books which are being solved and which are being put up there. There are recalls also, and these are the exam simulated scenarios what we have put up. And there are salt stations, there are PDFs that are available, which are again arranged module wise. And in the course telegram group, apart from the unlimited task, we have must have heard about the Rayz Warriors groups. We just constantly solve all the recalls and the exam scenarios in that particular group. We keep on the scenarios, particularly the students keep on posting their voice task and we give the submission. So way from all to 2.5 years plus, you can find out all the recordings over there, and how the practice and the immense amount of the practice recordings that are there. Every recording is precious, so just you can just listen to them in your free time also. It's going to add up much to your preparation. All the study materials, complete library access till your next exam, that is going to be provided. I don't think any other course gives you this kind of an approach and a feedback and everything that you want. We are going to provide you in this. So it's good that all of you are choosing Rayz Academy. Thank you for that. It's very essential that the course and the mentor that you choose, it's very important, and you're giving us an opportunity to be part of your success journey. So happy studying from entire team Rayz Academy. Schedule of which again I'll be posted. So I'll stop the recording at this level. We'll have some discussion.